spine is composed of 7 vertebrae, which are stacked one against each other. We have the first 2 vertebrae, which we call atypical vertebrae, because they are different in morphology from the rest of the cervical spine. We call the rest of the cervical spine the subaxial cervical spine, and we have the craniocervical junction, which is composed of the C1, C2, and the occipital bone. This is a lateral view of the cervical spine. We can see the C1 and the characteristic features of the C1, that it is a ring-shaped structure, and it has lost its body embryologically to be fused with the C2. So the body of C1 has been lost, and it is fused with the C2 to form what we call the odontoid process, the big or the dense. The other characteristic feature of the cervical spine is the short transverse processes, and what they contain was here, what we call the foramina transversum. The foramina transversum transmits the vertebral artery, and though the 7th cervical vertebrae has a foramen transversum, usually the vertebral artery will not pass through it, and it will start from the C6 upward, C1, C2, and the C1. The other features of the cervical spine is the bifid spinous processes. So if we look at the cervical spine at the posterior view here, we can see that the C1 has just a posterior arch and very rudimentary spinous process. We call it the posterior tubercle, while the C2 down to the C6, their spinous processes are bifid. Okay, and this serves for the muscle attachment of the cervical spine, while the C7, which sometimes is classified with the atypical cervical vertebrae, has no bifid cervical spine, and its spinous process is elongated. Let's have a look at the C1. So this is anterior view of the C1. As you notice, there is short transverse processes. This is what we call the lateral mass, which is the communication between the superior articular joint and the inferior articular joint, process or joint. Then we move to have a posterior arch with posterior tubercle, foramina transversum on both sides, articular surface, and we have the articular surface for the dense or odontoid anteriorly. I'll just show it again. So if we look at this one here, you can see this in the anterior arch, there's a place for the dense or the odontoid to articulate with the C1. Showing the C2, where it articulates with the C1 through the C1, C2 joint, okay? It's also worth noting that the C1 and the occiput articulation, which is happening here. The main movement of the C1, occiput C1 is nodding of the head. Okay, let's isolate the C1, and we look at this is the dense here, okay, or the odontoid process, the superior articular process on both sides, bifid spine, inferior articular process, and the foramina transversum. We can look and see that this is a bifid spinous process, so definitely this is from the cervical spine. If we look at the C7, and you can see how elongated the spinous process, and it lacks the bifid nature of the rest of the cervical spine. One important feature of the cervical spine is, just go back to this. Okay, we'll stop here. Is this ancovertebral joint. If you look at the body, they are concave, and they have these joints here superiorly that they develop in the adolescent life, and they become attachment between the vertebral bodies superiorly. These, we call them ancovertebral joints. These ancovertebral joints can be hypertrophied sometimes and cause compression on the nerves. Okay, let's look at this. So we have added most of the ligaments now, and I need you to remember all that the bone itself is basically pieces of Lego, okay? They are not attached to each other, okay, without the ligaments. So basically, if you stack them one against the other, they will not give you the benefit that you want. They need to be connected, and the forces, the structures that connect them are, we'll start about these in a second. If we look at the back of the spine, this is what we call the nuchal ligament or the nuchal fold. And this is extension of what we call the supraspinous ligament. It's very broad and very strong in the adult life. Okay, and then we have the interspinous processes ligament, which is connecting interspinous processes ligament here, which is connecting the spinous process with each other. It's more clear maybe in the thoracic spine. So this is the interspinous ligament. This is the supraspinous ligament. Okay, then we have the capsule of the facet joint. The facet joints are synovial joints, and the capsule is attached to the edges of the bone, as you can see here and here. In the cervical spine, these are very thin, very transparent, and intraoperatively, sometimes we cannot see them. We have this strong, broad ligament, which we call the anterior longitudinal ligament, which is attached to the foramen magnum, which is part of the occiput, the C1, C2, and it goes down to the sacrum or the pelvic surface of the sacrum, and this is what holds the anterior part of the spine. In addition to these, what we call intervertebral discs. To remember about the to recall some of your information from the anatomy, we have endochondral braids here, and in between we have the intervertebral disc. The intervertebral disc is the annulus fibrosus, which is the lamellar ligament, which is mainly of collagen, and then we have the nucleus bulbosus inside the annulus fibrosus, and this gives us the hydrostatic pressure that maintains the shape and the height of the intervertebral disc. We have added the vertebral artery, so you can notice where the vertebral artery passes through the foramina transversum, and I think, yes, they did it right here. The vertebral artery is not passing through the foramina transversum of C7. And if you look here, we have the dural sleeve. The gray thing here down here is the dural sleeve. And this is part of the dura that follows the nerve root at its exit and ends just beyond the foramen. And then we have the nerve roots coming out to the outside, and they attach to each other, making the brachial plexus. Again, we are looking at the spine, the anterior longitudinal ligament. Anteriorly, posteriorly, we have the nuchal ligament, supraspinous ligament, interspinous ligament, and ligamentum flavum. We move to the lumbar spine. And in the lumbar spine, you can see similar things. There's the capsule here, which is surrounding the facet joint. Then we have the ligamentum flavum, which arises from the lamina above. So this is the spinous process. This is what we call the lamina. This is the superior articular facet, inferior articular facet, and in between, this structure which connects the superior articular facet with the inferior articular facet is what we call the pars interarticularis. Between the lamines, we have a ligament which called ligamentum flavum, and this is important when we discuss a pathology called lumbar canal stenosis, because it becomes hypertrophied and it will compress the cauda equina in the lumbar spine. Again, you can see these spinous processes: supraspinous ligament, interspinous ligament. Anterior longitudinal ligament goes down to the pelvic surface of the sacrum. We can see the dural sleeve surrounding the nerve root, and then the nerve roots come to the outside. And if we stop here, ligamentum flavum, then you will have the dura, and anterior to the dura, there is the posterior longitudinal ligament. Hopefully we'll see it in a minute, supraspinous. If we look at the intervertebral disc, we can see that the outer part of it, which is lamelles of collagen, which is called the annulus fibrosus. And then in the midline, we have the nucleus pulposus, which contains protoglycan, and 80% of it is water. And connection between thoracic spine and the ribs. وهي من ميزات، لأنه لما أخذتوا محاضرة التروما يمكن حكى لكم الدكتور سالم إنه thoracic spine mostly the fractures فيها are stable fractures. والسبب انه في عندنا الريب كيج وفي عندنا الستيرنم are holding these spine together. فاذا بنطلع على هذا الhead of the rib, there's two articulation surfaces between the head of the rib and the vertebrae, one with the vertebrae above and the other one with the vertebrae below. The third one is with the transverse process, and this is give a strength to the thoracic spine compared to the rest of the spine. راح ننزلهم هلا ونشوف anterior view. زي ما انتم شايفين ال head of the rib is articulating with the superior vertebrae and the inferior vertebrae. أو شفنا posterior لأنه the body of the rib is articulating with the transverse processes. Zooming in. هلا راح نحكي عن radiological anatomy. Radiological anatomy is very important because most of the time you will end by requesting images for your patient. فراح نبدا بالcervical spine. و to be adequate cervical spine زي ما انتم كلكم بتعرفوا من الجنرال surgery انه it should include the junction of the C7 2 3 4 5 6 7 T1. يعني اذا انا radiographer صور لي صوره وكانت فيها بس ل C5, this is inadequate cervical spine image, وبالتالي لازم C7 T1 junction يكون clear. نطلع على الاناتومي مره ثانيه بنحكي عن C1, which is a ring-like structure. This is the posterior arch of the C1, and this is the anterior arch of the C1. Okay, then we look at the C2, and this is the C2 spinous process, lamines, the lateral masses, laminae, and the posterior spinous process. And this is where the dens goes up, and here it where it articulates with the C1. And we call this again the dens, odontoid, and the big. Okay, it is the same nomenclature. The axis, because it is known محور, الأكسس هو المحور, عشان هيك لأنه هاي it will articulate مع C1 cause this movement, عشان هيك بنسميها الأكسس. الأطلس من الجريك methodology أو C1 من الجريك methodology is the god who holds the earth. فعشان هيك الأطلس هي C1 بسموها الأطلس. We move to C3 وبنشوف nice borders. This is a nice normal cervical spine. We see the vertebral body, intervertebral discs. We can see the lateral masses, which is the connection between the superior facet joint. This is the superior facet joint, and the inferior facet joint. We see the laminas, and then we see the spinous processes. We move on. After this one, we will have a look at the AB views of the cervical spine. And in the AB view, again, you will see the ancovertebral joint. You remember we spoke about the ancovertebral joints with their articulation between the superior vertebral body and the inferior vertebral body of the vertebrae above. This ring-like structure here is the attachment of the spinous processes to the lamina, and we can see the areas of the lateral masses here and here, and this is a facet joint. Another view of the cervical spine is the one that we call an oblique view. We rarely use this one, but this one is good because it shows us the foramens where the nerve root exits the cervical spine. And if there's osteophytes, which we will talk about later, these osteophytes can cause compression on the nerve root at their exit foramen, and we can see them here compromising the foramen. We rarely use this since the advent of MRI scans and CT scans, but still it is a practical X-ray if you need to do it. The other one, which is very commonly used, is the open mouth view, and this is very typical for the dense fracture or the odontoid fracture. This is the C1 lateral mass, and this is the lateral mass of, or the superior articular surface of the C2, and this is where the C1 and C2 articulate on both sides. And we can see the dens or the odontoid process around here, and this is the vertebral body. In cases of a fracture, we have the spin spool or the overhanging of the C1 on C2. We can see that this lateral mass is deviated laterally, and this one is deviated to the other side. If the distance is more than 7 millimeters, we may classify this as a Hangman fracture. I don't think this is important to you. I just want you to know that this is what we call open mouth view, and you recognize the anatomical landmarks. Okay, let's move on from the X-rays to the CT scan. And this is what we call a sagittal bone window CT scan of the cervical spine. And if we move to the midline of the cervical spine MRI scan, superior articular surface with the inferior articular surface are making the facet joint. This is what connects of the superior articular surface with the inferior in the same vertebrae, and this is what we call the lateral mass. This is where the the foramina transversums are, and then we move medially. When we move a bit medially, we can start to see the small, short pedicles. We usually miss them on the CT scan because they are short and small. And then we look at the vertebral bodies here. And this is the C2. Again, the C1 is a ring-like structure. This is the foramen magnum. It's important to notice that if the dens is protruding forward through the foramen magnum, this is what we call basilar invagination, where the odontoid process goes through the foramen magnum, and this signifies some occipito-cervical junction, either anomaly or subluxation. Just to let you know about it. Spinous processes. Okay, these are the bifid ones, and this is the one of the C7, which is not bifid, rounded, elongated. Okay, let's see some axial images. Again, vertebral body. Okay, this is the anterior arch of the C1, and you can see the dens. We have the transverse ligament coming across here, which holds the transverse against the C1 arch. There's an articular surface between the C1 and the C2. This is the anterior tubercle, which is part of the anterior arch and serves for the longusculi attachment. Again, this is the beginning of the body of the C2 vertebrae and the attachment of the dens to the C2 vertebrae. Okay, vertebral body, anterior, facet joints, superior articular surface, inferior articular surface, lamina, and this is the spinous process. Foramina transversum, part of the transverse process or within the transverse process, and this is what transmits the vertebral artery. Okay, this is an MRI scan of the cervical spine. This is a sagittal view, and this is a T2 sequence. And the reason why it is T2 because the CSF is hyper intense. That's to say it is white. Again, we have the cerebellum here on the back of the head. We have the pons, and the pons is a rounded structure. Then we have the medulla oblongata around here, the level of the foramen magnum, the C1 anteriorly and posteriorly, the C2 or the odontoid process or the axis. Then we have the intervertebral disc. Then we have the vertebral body. As we discussed, that the nucleus pulposus is mainly water, and that's why a healthy disc space will look like this one, has a gray signal with some hyper intensity because of the water content inside it. The more dark the disc space and loss of the height happens, this is pathological disc spaces. Not necessarily every pathological disc space on the MRI scan will cause symptoms. Actually, most of the changes or the radiological changes that we can see in the spine are asymptomatic. That's to say they are not causing any symptoms. And that's why most of the time we don't treat the images. Well, we always don't treat the images. We treat the patient's symptoms. And please keep this in your mind, because as GPs, you will get the report of the MRI scan or the cervical spine X-ray or CT scan saying there's osteophytes, there's degenerative changes, there is. lots of positive finding on the images, but actually the patient is fine. He's not complaining. Okay, so we don't treat it unless it is causing symptoms. And most of the degenerative disease are part of aging process. So we will see a lot of these changes on the MRI scan, on the CT scan, but they are asymptomatic. This is the spinal cord. And when we see CSF surrounding the spinal cord, we can tell that there is no compression on this spinal cord. Lateral masses, facet joints. We'll move on to axial images. Again, the spinal cord here, spinous processes. Okay. So this is the axial T2 images. And this is at the level of the thoracic spine, basically because there is a rib here. And as we discussed, there's a communication between the body of the rib and the transverse process. There's a communication between the vertebral body and the head of the rib, vertebral body. This is elongated pedicle. If you see, because this is a thoracic spine, we can see a nice pedicle. In the cervical spine, the pedicles are very short. And that's why when we do an instrumentation or when we put screws in the cervical spine, we put them most of the time on the lateral masses rather than in the pedicle. For the rest of the spine, we put our screws into the pedicle itself. And the reason, again, because the pedicles of the cervical spine are very short and narrow, so they cannot accommodate the pedicle screws. While thoracic spine, you can see there's enough space to put a screw from here down the pedicle to the vertebral body. This is the spinal cord, which is the gray and surrounded by CSF. And then we have the spinous processes and we have the muscle attachment. The lung is here. Move on. Again, we are coming now on the more images of a cervical spine, vertebral body, vertebral artery, the superior articular process, inferior articular process, the facet joint is here, spinal cord, and the nerve root is exiting through here. I'll try to show you a small, so this is a pedicle. This is the pedicle of the cervical spine. You can see how narrow, short, and laterally oriented. So to get a screw on this trajectory, it will be amazingly difficult. In addition, it is very close to the vertebral artery, and this causes risk of injury to the vertebral artery. We become wider space, foramen magnum. This is the medulla, cerebellum, the hemispheres, and this is CSF surrounding the medulla. Let's move on to the lumbar spine X-rays, and you can see this is an AP view X-ray of the lumbar spine. We can show you here the vertebral bodies. These here are the spinous processes attachment to the laminas. What we see here is the attachment of the pedicles to the vertebral bodies. Okay, sorry, let's go back to that one. These are the transverse processes around here. This is the disc space. The area here, which is clear or a bit dark, is the interlaminar space, or the space where there's no laminas. The lamina will be above and below, and this is the interlaminar spaces. If we come down here, we can see the communication between the sacrum and the pelvis at what we call the sacroiliac joint. So this is the sacroiliac joint. Again, transverse processes, vertebral bodies. Let's see this vertebral body, pedicles around here, spinous processes, intervertebral disc, and we can see the ribs communicating with the vertebral bodies. Let's move on a little bit for the lateral view. Again, there's some lordosis. This is not a typical lordosis, but let's see, this is the vertebral bodies. Here, another vertebral body. They are attached to the posterior compartment by the pedicles, and you can see that the pedicle is wide and long enough to insert a pedicle screw in this trajectory. It's important to know that the pedicle has the inferior notch on its inferior surface and another notch into its superior surface, and this will result in the formation of the intervertebral foramen, where the nerve root will come to the outside to join the lumbosacral plexus or the cervical plexus in the cervical spine. So again, we can note that if there's a disc here and it goes posteriorly, or we get a prolapsed disc, it may compress the nerve root into the foramen, or if we got osteophyte due to secondary changes, this osteophyte will grow posteriorly and compromise the nerve root. So you can see the faded area here of the spinous processes. The laminas are around here, and these are the facet joints. Again, this is a CT scan of the cervical spine, of the lumbar spine. You can see the vertebral body here, okay? Then the vertebral body here is not yet complete, but this is the pedicle connecting it to the posterior compartment. This is the superior articular surface of this vertebrae. So this is L5, this one is L4, and this is the superior articular surface of the L4, and this is its inferior articular surface. The area in between them is called the pars interarticularis. This is the inferior notch on the pedicle, and this is its superior. The superior and the inferior notch will make the intervertebral foramen, which transmits the nerve root. Okay, this is almost a mid-sagittal, or in the midline, and we can see the vertebral bodies, intervertebral disc, and the spinous processes posteriorly. This is the facet joint, the superior articular, inferior articular process of L4, superior articular process of L5, and again, this is the pars interarticularis. I keep reminding you about the pars because we get a pathology called spondylolisthesis, where there's either traumatic fracture on this area, or a congenital fracture, or lytic or degenerative fracture that results in the whole spinal column above the fracture to move forward, and this one will stay backward because it is attached to the pelvis. And once this moves forward and this one stays fixed, the disc space, or the intervertebral disc, will move backward and cause compression on the cauda equina and the nerve roots here. Let's continue. So again, we will look at the axial images of the lumbar spine. The first one was a thoracic. Then this is the vertebral body, pedicle, superior articular surface, inferior articular surface of the vertebrae above, facet joint, or the line of the joint, and we have the transverse processes around there. Transverse process, this is the TP. So our pedicle screws goes through this direction. Spinous process. And lastly, we'll be looking at the lumbar MRI scan. Pedicle. So these are the vertebrae, healthy disc spaces, because they have hyper intense or bright signal on a T2. That means they have a nice content of water inside of them. Then we have the CSF surrounding the cauda equina, and that's 0, 5, 4, 3, 2, 1. This patient probably has a lumbarization. If you remember, the cauda equina, the conus medullaris osteospinous cord will terminate at the level of L1, L2, and then after that, the nerve roots will leave the spinal cord and swim into the CSF in the lower lumbar spine, and this is what we call cauda equina, down to there. If we look at these, so this is the S1, this is the sacrum, okay, and this is the S1 nerve root. You can see the duthecal sac, or the dura, are becoming less and less crowded from the nerve roots. We'll see how crowded it is on the top. S1 nerve root. Then we have the L5 forming there and there, and it goes inside. And you can see how become more nerve roots are inside the thecal sac or the dura until we reach the level of the conus medullaris. Okay, احنا غطينا أول 2 topics من ال degenerative disease of the spine اللي هم gross spinal column anatomical feature و radiological anatomy. راح نبلش نحكي هلا عن intervertebral anatomy and physiology. بعدين راح نحكي شوي عن ال clinical presentation of degenerative disease و management of these degenerative diseases. فنرجع مرة ثانية واحنا حكينا هذا انه ال intervertebral disc is made of the annulus fibrosus and the nucleus bulbosus inside. The layers of collagen fibers هم عبارة عن type 1 collagen fibers made into lamines وفي some radial fibers بكونه و it is thicker anteriorly من posteriorly و it is attached to the end plates اللي هم هنا. في عنا cartilage fibrocartilage بنسميه ال end plates وهدول ال annulus fibrosus إذا شايفين على الصورة attached لل fibrocartilage وفي الوسط عنا للnucleus bulbosus. الnucleus bulbosus الفانكشن تاعتها to offload الcompression forces يعني وانت نايم على ظهرك ما راح يكون في compression على الannulus fibrosus. لما when you stand up or you are sitting راح يكون في عندي axial load or compression وهذا will deform the annulus fibrosus but it is temporary لانه بنعرف انه الهيدروستاتيك بريشر في النيوكليوس بالبوسس راح يرجع الامور الى ما كانت عليه. هلا لما يصير في عندنا degeneration ونخسر الانيولس فايبروسس راح يصير في عندنا diffuse disc bulge زي ما انتم شايفين بهاي الصوره. اوكي slide. مره ثانيه it is water. This is very important لانه لما نحكي عن acute disc herniation خلينا نفترض انه خلينا نحكي شوي عن disc herniation. في عندنا نوعين. في عندنا نوع اللي بيصير في ال young age middle age group خلينا نحكي 30s 40s حتى بال 50s بنشوفه مرات بنشوفه في الالدرلي بس it is more common في ال young age group. بيكون في عندنا الديسك بصير في عندنا cracking للانيولس والسوفت ديسك راح يطلع من مكانه ويسوي compression في المنطقه هاي على النيرف روتس. هلا because it is soft disc و it is mainly water it will get reabsorbed. الووتر منه يصغر حجم الديسك ويقل الحجم الضغط عن النيرف روت وبالتالي السيمتومز راح تتحسن مع مرور الوقت. وعشان هيك في الاكيوت ديسك برولابسز احنا ما بنسوي سيرجري. we don't advise surgery في هاي الحالات الا اذا كان في special indications زي انه المريض يكون عنده neurological deficit. اما غير هيك بنستنى 3 to 6 months للimprovement of symptoms spontaneous improvement بتتحسن. بس لما يكون في عندنا degenerative disc يعني النيوكليوس is dry اوكي وزي ما انتم شفتوا هون dry nucleus وفي عندي الانيولس فايبروسس عم بصير له broad disc protrusion عم يطلع لبرا. هذا راح يكون صعب انه يرجع يتحسن لحاله او بتحسنوش هذول المرضى لحالهم في اغلب الاوقات وبالتالي هذول بصير indication for surgery اسرع من المريض اللي عنده acute disc prolapse. لما نحكي عن molecular biology في عنا risk factors وفي عنا molecular processes. risk factors aging, trauma, genetics, metabolic, obesity كل هاي الأمور may accelerate or increase the risk of having degenerative disc disease. على level of the cell واللي بتصير على level of the nucleus bulbosus mainly it is dehydration. We get loss of the protoglycan, catabolic anabolic imbalance, inflammations, some cell death and some cell senescence. طب ايش اللي بصير اذا ما تصير هاي الموليكولار بروسيسز؟ عم نخسر اللامينا اللي موجوده حول الانيولس فايبروسس. لما تخسر اللامينا تاعتها معناته النيوكليوس بالبوسس عفوا الانيولس فايبروسس النيوكليوس بالبوسس will spread وبالتالي الاريا اللي هي contained within it راح تصير اوسع وبالتالي الهايت اوف ذا ديسك will start to collapse. ممكن يصير في عندنا cracking, tears and fissuring وهذا ممكن يسوي لنا stenosis, bulging, herniation و instability. طبعا راح نحكي عنهم بالتفصيل كمان شوي. طيب بشكل عام if we are talking about the spine اوكي ايش السيمتومز اللي ممكن يجي فيها اي مريض spine؟ basically هم 4 symptoms، ونادر ما يجينا مريض بأي symptoms غير هدول الأربعة. الأولى هي البين، وهذا most common symptom اللي بيجونا فيها الغلطة. بس we have to differentiate different types of pain. في عندنا mechanical pain أو axial pain، وهذا بتشوفوه راح تشوفوه كثير كجي بي، راح يجيك المريض على الطوارئ أو في العيادة يحكي لك دكتور عندي وجع في ظهري. هلا it is important في الهيستوري إنه to know هذا الوجع is it moving somewhere, is it going down his leg, how chronic is it, is there any risk factors أو red flags اللي راح نحكي عنهم من شوي، عشان نعرف هل هذا المريض needs just painkillers وفيزيوثيرابي وconservative treatment without imaging، ولا نحكي له لا انت في عندك ريد فلاج. مثلا اذا كان المريض عنده history of cancer، اوكي، المريض عنده osteoporosis، it could be metastatic spine disease هو the cause of these symptoms. فبالتالي we have to act rapidly on these patients by doing more images and trying to diagnose the cause of their mechanical back pain. بس لو فرضنا بنحكي عن شاب بالأربعينات أو بالثلاثينات أجا بشكي just back pain localized to the lumbar spine, no radiation of 2 days duration after certain effort. This is mostly muscle sprain, ligament strain, and this needs conservative treatment with painkillers. ثلاث المريض painkillers, physiotherapy and rest. طبعا physiotherapy احنا ما بنفضل نعطيه في الاكيوت ستيج، بنعطيها في later stages. وبعدين بتحكي للمريض بتراجعني بعد اسبوعين او ثلاثه بتشوف if his pain is resolving. If it is resolving, you don't have to do any imaging and that's it. We are done. هلا إذا كان pain persistent and it is not responding after 1 month to the painkillers, then this is a red flag. You should be worried about it. And especially إذا كان constant pain, you should do more imaging and investigations. رح نحكي عنه بالتفصيل. The other type of pain that the patient can come with is radicular pain. And the radicular, it denotes problem in the nerve root, which means each nerve root زي ما أنتم بتعرفوا has a specific dermatome و specific myotome. لما يكون في عندي pain بينزل من النك down to the arm and down to the thumb. This is C6 nerve root and this is associated with numbness and paresthesia. This is radicular pain. The most common cause of radicular pain is disc prolapse causing compression on the nerve root. Can it be other causes? Yes, it can be. Infection in the spine can cause compression on the radicular pain. Spinal tumors can cause compression on the nerve root causing radicular pain. Fractures can cause compression on the nerve and cause radicular pain. So all of these can cause radicular pain, but the most common cause is spine degeneration or disc prolapses. And that's why most of the time we treat this depending on the age of the patient and the symptoms. So if the age of the patient is young and we think it is a soft disc prolapse, there's acute onset of the symptoms, we just treat them conservatively for a few months. Then زي ما حكينا, this is a scan soft disc prolapse, will get absorbed and disappear. The symptoms will get better, okay? If it is a hard disc prolapse or kind of osteophyte disc complex, وراح نحكي هلا اللي بصير انه احنا في عندنا الفيرتبري وفي عندنا الديسك in between them. بس يصير طبعا الفيرتبري جزء مهم من الانترفيرتبرال ديسك. Function is the nice movement. Degenerative changes إذا كانت osteophyte وديسك prolapse which is diffuse disc bulge لأنه صار في عندنا dehydration of the nucleus pulposus. These ones may respond to conservative treatment, but في أغلب الأحيان they would require surgery. And this is the difference between solid or hard disc prolapse and a soft disc prolapse. Pain, radicular pain, وآخر شيء في عندنا referred pain. Referred pain في عندنا two types of referred pain في الspine. Preferred pain إنه أنت يكون في عندك pathology distant from the spine that cause back pain or spinal pain. So a good example دائما اللي هو aortic aneurysm, abdominal aortic aneurysm. It can present with acute lower back pain. المشكلة الثانية إنه يكون العكس، إنه عندي spinal pathology that can cause referred pain somewhere else. مثال عليه الفاسد joint disease. الفاسد pain L4-5 vertebrae can cause anterior thigh pain. فأنت ممكن تفكر إنه هذا hip problem, which is actually is a facet joint problem. Okay. راح نحكي عنهم برضه كمان شوي بالسلايدات بالتفصيل اكثر. الاذر سيمتوم اللي ممكن يجي فيها المريض neurological deficit، ممكن يكون sensory loss of sensation due to compression on the nerve root, or إذا كان severe enough it will cause loss of sensation on the specific nerve root distribution أو compression على الspinal cord itself، وهذا ممكن يكون حسب anterior, posterior or lateral compression، أو واحدة من السندرومز اللي حكى عنها الدكتور سالم أكيد امبارح في التروماتيك spine injury زي براون سكارد syndrome اللي هي hemitranssection of the cord، central canal syndrome، anterior spinal cord syndrome أو posterior cord syndrome. وطبعا في عنا motor symptoms في neurological deficit زي upper motor neuron lesion. طبعا motor بالعادة weakness، ممكن يكون upper motor neuron lesion لما يكون في عنا compression على spinal cord من cranioscervical junction down to the conus، أو lower motor neuron lesion زي لما يكون في عنا compression على nerve root it's causing weakness in the myotomal distribution. الميوتوم هو area is a group of muscles supplied by a single nerve root. Dermatome is the skin area supplied by specific nerve root. واخر شيء من النيورولوجيكال سيمبتومز اللي ممكن تكون اوتونوميك اللي هو زي mainly انه يكون في عندنا urine and stool incontinence او urine retention. في عندنا set of symptoms اللي ممكن يكون زي المايلوباثي والنيوروجينيك claudication، هذول راح نحكي عنهم بالتفصيل. واخر شيء which is very rare انكم تشوفوه كجي بيز، بنشوفوا احنا كنيوروسيرجن وسباين سيرجن لهم السكوليوسيس والكايفوسيس. But basically these are the symptoms from the spinal pathology. Very rare انه تشوف symptoms ثانية جاي من spinal pathology. But details of each of these, like detailed history about the pain, location, radiation, duration, relieving factor, aggravating factor, should give you a good hint about the cause of the pain, وبالتالي diagnosis, or at least the level الشغلة الثانية، هل هو cervical، هل هو lumbar، هل هو thoracic spine. Okay, clinical presentation. Pain. We spoke about this. Mechanical or axial neck pain. So the pain is localized to the neck or the lower back. Usually في non-sinisterous or non-insidious pain المريض بحكي لك لما أوقف بزيد الوجع لأنه you are loading the spine، أو مثلا في المسل strains بحكي لك طول وأنا ثابت ما بتحرك الوجع محتمل، بس أتحرك أو أسوي specially twisting movement بزيد البين. The pain does not go down to the limbs, otherwise it will be called referred or radicular pain. We don't get worried about this pain unless there is red flags like history of cancer, weight loss, fever, temperature, patient who are immunocompromised, like patients who have diabetes mellitus or HIV. These patients have a high risk of developing spinal infection like discitis or osteomyelitis, and this can be worrying. The other type of pain is the radicular pain, and this is what we said about is pain on the distribution of a specific nerve root, and this is what you have to memorize by yourself. C4-5, the nerve root will be affected is the C5 nerve root, and this will cause pain and that distribution, and in severe cases sensory loss and weakness in the distribution of the myotome. هذا التابل والتابل اللي بعده اللي عن اللمبر سباين you have to memorize it. بصراحة ما في شيء أشرحه لأنه it's clear where is the pain, where is the sensory deficit, and there's the weakness. One important information ذكر إنه في عنا 8 cervical nerve roots بينما عنا 7 vertebrae only. فأول nerve root اللي هو موجود 50% من البشر بس بيطلع above the C أو 25% مش موجود عفوا 25% من الناس ما عندهم C1 nerve root. بيطلع above the C1. okay. C2 بيطلع above the C2. C3 above the C3. C7 above the C7. C8 above T1. فإذا أنتم شايفين الصورة عندي هون، الصورة هون C7 تحتها C8. طبعا أنا تحت C8 تحت السي 7 عندي تي 1 فيرتبري، فبصير في عندي تغيير بالتسميه. النيرف روت هنا كان يتسمى بيعتمد على الفيرتبري بيلو في السيرفايكال سباين، فالسي 7 اوكي نيرف روت بيطلع above it، التي 1 نيرف روت بيطلع below it، وهذا بيكمل لنوصل لللامبر سباين. النيرف روت below L4 is L4, below L5 is L5, below S1 pedicle is the S1 nerve root. Okay. هلا clinically this will not cause any problems for you except في what we call the far lateral disc. ليش؟ إذا أنتم شايفين بالcervical spine النيرف root C6 goes below it and it is almost horizontal. واضح الصورة إنه horizontal، فبالتالي disc prolapse at C5 C6 will cause compression of the C6 nerve root. Similar below it C7 nerve root between C6 and C7. طب ايش اللي بصير في ال L4-5؟ L4 5 disc إذا شايفين النيرف روت عم بيطلع قبل الديسك space and then leave below the pedicle without transversing the L4 disc space. Okay, what transverse the L4 disc space is the L5 nerve root. واضح؟ فبالتالي دائما الكمبريشن على الليفل below، يعني C5-6 C6 L4-5 L5. اوكي، لحد شغله معينه اللي بنسميها far lateral disc او extra foraminal disc. اذا كان الديسك عم بيطلع laterally هون راح يسوي compression على L4 على L4 nerve root مش على L5 nerve root. فبالنسبه لكم ما بهمني تعرفوا شيء عن lateral disc بصراحه او عن extra foraminal disc. It is too advanced بالنسبه لكم. بهمني تعرفوا عن اللي بنسميهم central او paracentral disc prolapses، ودائما بالتالي C5-6 بيضغط على C6، L4-5 بيضغط على L5، يعني بنسمي النيرف روت that can have the compression بناء على الاسم تاع vertebrae below. بس الفرق انكم تكونوا عارفين انه السبب هنا انه these horizontal these are vertical، عشان هيك مع الرغم من التغيير اللي بصير في الاسم بسبب C8 نيرف روت الكمبريشن على النيرف راح يضله نفسه. بالراديكولار بين في عندنا سبيشال تيست بنسويهم تو كونفيرم. بالسيرفايكال سباين في عندنا برضه سبيشال تيست بس I usually don't do them because they are painful و they are not very sensitive. بس باللمبر سباين البرايمري فوكس على بوست نيرف روتس اللي هم L5 والS1 اللي هم 98% من الديسك برولابسز. هذول التيست بنسميهم ستريتلي جرايزنج تيست، بمعنى انا بحكي للمريض ينام على ظهره، اوكي، بنام المريض على ظهره وبكون he's free of pain. بعدين I start gradually to lift his foot off the bed وبحكي له لما يصير الوجع اللي بيجيك احكي لي. لما نوصل لمرحله معينه المفروض ترفع رجلك 80 ل 90 درجه بدون ما يكون في عندك radicular pain. هلا المرضى هذول بصير عندهم البين earlier، يعني ممكن يكون على 30 degree 40 degree انا عم برفع في اجره ويحكي لي البين هلا عم ينزل down to my leg، فبعرف انه this is positive for compression on L5 L4 5 and S1 nerve root. هلا في عندي اللازيك تيست اللي هو شبيه بالستريت ليج رايزنج تيست، انه انا بسوي ستريت ليج رايزنج تيست بضل ارفع اجره لما يحكي لي بلش الوجع، بعدين بنزلها شوي صغيره لحد ما يختفي الوجع وبسوي dorsiflexion of the foot. بسوي dorsiflexion of the foot I will cause tension on the sciatic nerve and this will cause reproduction of the symptoms. اوكي، الاذر تيست اللي بنسويه اللي بنسميه cross leg rising test، بمعنى انه المريض اذا رفعنا اجره الثانيه، عفوا مش هذا السلايد، انا راح اشرحه لانه شكله ما فيش سلايد عليه. بخلي اجريه الثنتين على البيد وبرفع اجره اليمين، هو موجوع بالاجر اليسار، برفع اجره اليمين شوي شوي. اذا كان الكروس ليج تيست بوزيتيف بعد ما اوصل 30 40 او 50 درجه راح يصير في عنده راديكولار بين على الليفت سايد، وهذا اللي بنسميه كروس ستريت ليج رايزنج تيست. C2 C3 ممكن يسوي لي اذا في عندي degenerative changes بالفاسد جوينت، ممكن يسوي لي occipital headache، ممكن يكون عندي shoulder headache، interscapular pain من C5 6 عفوا من C6 7. ممكن يكون في عندي C5 6 يعطيني shoulder pain. نفس الشيء في اللمبر سباين ممكن يكون عندي anterior thigh pain اذا في اي degenerative disease of L3 ل S1. يعني اي واحد منهم ممكن يعطيني anterior thigh pain، وهذا ممكن confusing الدياجنوستس تاع facet joint pathology مع الهيب joint pathology. عشان هيك كنيوروسيرجن او كجنرال براكتيشنر لازم تعرف how to examine the hip and how to examine the spine. Again referred pain من السياتيك. هذا اللي عندنا على الرايت سايد هذا بين من الاورتيك انيوريزم. بنشوف انه it can cause lower back pain او thigh pain. وبينما كمان اذا patient عنده kidney stones ممكن يعطيني pain in the back ونحسب انه هذا المريض عنده degenerative spine disease. واذا بتتذكروا انا حكيت لكم بنشوف كثير صور راديولوجي بيكون فيها degenerative disease of the spine. وعشان هيك ممكن هذا المريض يجي باك بين نروح نصوره صوره اكس راي لللمبر سباين لانه احنا ما اخذنا هيستوري دقيق منه، ونشوف degenerative changes ونحكي له الباك بين تاعك سببه degenerative disease of the spine while it is actually stones. فعشان هيك associated symptoms في الهيستوري في dysuria، في risk factors، في intermittency في اليورين، في urine incontinence. كل هاي it will guide me towards where is the pathology. Is it in the spine or it is the kidneys. نفس الشيء في الاورتيك ابدومينال انيوريزم في peripheral vascular disease، في عندي ischemia في اللور limbs، pallor، في عندي loss of pulses. All of these will guide us towards that the problem is in the aortic aneurysm, is not in the back, or if the patient has back pain, long standing, it is most likely degenerative disease of the spine rather than acute or abdominal aortic aneurysm dissection. Neurological symptoms حكينا في عنا sensory ممكن تكون pins and needles, numbness, sensory gait imbalance, affection of the dorsal column, loss of manual dexterity, loss of proprioception in the hands. بيجي بيحكي لك المريض الشغلات بتوقع من ايدي، القلم بقدرش امسكه واسيطر عليه، الزرار تحت القميص ممكن ما يعرفش يسكرها كويس. This is because of loss of manual dexterity. With differential diagnosis of manual dexterity is vast. There's lots of causes. It can be parietal lobe syndrome. It can be problems in the level of the brainstem. It can be Parkinson's disease. All of these can cause loss of manual dexterity. But if there's associated symptoms for examination, like pins and needles, it is very unlikely it is a Parkinson's disease. Okay. If in the examination there's hyperreflexia in both lower limbs, there is clonus, and there's Hoffman sign positive. This will guide me that this is cervical myelopathy or compression on the cervical spine causing these neurological symptoms. Motor, upper motor neuron weakness, lower motor neuron weakness, difficulty walking or especially climbing stairs because of the spasticity and gait disturbances. Autonomic dysfunction, we said about urine and stool incontinence. Deformity, scoliosis, which is a deviation of the spine from one side to another. And then the scoliosis, just to have an idea, I'll tell you, we have the adult and pediatric. In the pediatric, there's something called the neuromuscular scoliosis, which is due to weakness of the back muscle and other pathologies like Duchenne muscle atrophy, like CB patient, cerebral palsy patient, they can get scoliosis. And we have the idiopathic adolescent scoliosis, which we don't know exactly the reason. It happens around the age of 5. They start to notice deformity, and they have intact muscle. There's nothing wrong with their pathology, but they just get scoliosis. And lastly, we have the adult scoliosis. And the adult scoliosis is usually degenerative because one of the disc spaces is affected or degenerated in one side more than the other. We may get scoliotic deformity. The other deformity we can get is the kyphotic deformity, which is in the sagittal in the sagittal plane. We lose. There's exacerbation of the kyphotic curve, and there's different types of the kyphosis. We'll not go through this. I just want you to know the nomenclature of these and understand that these can be presentation of spinal diseases. Okay. Myelopathy, so it is upper motor neuron lesion, and it is due to pathology of the spinal cord itself. So it can happen from the cervical spine, thoracic spine, or the level of the conus medullaris. The causes of myelopathy, usually compression. The compression most of the time is secondary to degeneration of the spine or acute disc prolapse, but it can still be due to compression from tumor, compression from infection, or from a trauma. So you have to think about these as possible causes of myelopathy. It is not only the degeneration. Also, myelopathy symptoms can happen due to pathologies intrinsic to the spinal cord. So it is dysfunction of the spinal cord itself, like transverse myelitis. The spinal cord tumors can cause it. Some people with ependymoma, astrocytomas can present with myelopathic features. What are the features? Sensory, numbness, tingling, paresthesia, loss of manual dexterity, imbalance because of involvement of the dorsal column, sometimes the axial skeleton symptoms like stiffness in the neck or the thoracic spine. We do classify the cervical myelopathy by different classification systems, like the Nordic classification. The other is Japanese Orthopedic Association classification. These for you just to know the basic principles of these classifications rather than the details. Okay, we come to something called the neurogenic claudication. And most of you here, the claudication in vascular rotation or in general rotation or general surgery rotation, like vascular claudication, which is typical for peripheral vascular diseases. The neurogenic claudication is usually due to lumbar canal stenosis. It is cervical spine. It does not happen in the thoracic spine. We can get cervical canal stenosis, we can get thoracic spine stenosis, but we don't get neurogenic claudication from these stenoses. We get neurogenic claudication from the lumbar spine. And the difference, because in the thoracic and the cervical, we have spinal cord, and the spinal cord compression will result in myelopathy, while compression in the whole cauda equina, gradual onset, long-standing, will result in a neurogenic claudication. So what is the neurogenic claudication? It's abnormal symptoms, usually sensory, in the lower limb with no specific dermatomal or myotomal distribution. It usually happens in elderly. They walk for a short distance. They get these abnormal sensation in their legs, so they have to stop walking. Very similar to the vascular claudication, but here's the difference. In the neurogenic claudication, they have to sit for a long time, usually 3 to 5 minutes, before their symptoms improve and they can walk again. While the vascular, it happens on the spot. They just sit down, the muscles switch from the anaerobic to aerobic respiration, and their symptoms will disappear quickly. The other thing that is different, if the neurogenic claudication in the patient, they will improve if they are bending forward. And this happens when they are doing their shopping and bending on the shopping trolley. They say they can walk for long distance, because once they bend forward, the thickened ligamentum flavum will be stretched, and this will give more distances in the lumbar canal stenosis and give more chance for the nerve to breathe. Similar thing will happen in the when they cycle. So if you put these patients with a neurogenic claudication to cycle, because they are bending their back forward, they will get improvement in the dimension of the lumbar canal, and thus they will not have symptoms. While the vascular, this will not change anything for them. They will still have the pain on a fixed distance. What is the red flags when we get worried, especially for cancer in the spine? Age above 40, history of cancer, unexplained weight loss, no relief with bed rest, because the most common cause, what was the metastatic spine disease will cause, is instability of the spine. And when you lie back, you are not loading your spine, and so the pain disappears. But when they sit up or they stand, they will get the pain. And if the pain is persistent for 1 month. Others, cauda equina, we get worried about the motor sensory loss and urine retention, the fractures, that there's a history of trauma, and the prolonged corticosteroid use because it causes osteoporosis, and in elderly. Infection, if they have spinal procedure in the last 12 months, immunocompromised people, intravenous drug abusers. Malignancy, if there's history of metastatic cancer, and in unexplained weight loss. Let's talk about the investigations. Diagnostic or golden standard of the investigation is the MRI scan, because it can show me the bony structures, and it can show me also the nervous tissue in addition to the soft tissue, which is very clear. So we can see the disc prolapses, compression on the spinal cord, the hypertrophy of the ligament inflatum، وراح نشوف امثله كمان شوي في الحالات كيف بتكون الامور واضحه. متى بسوي السي تي سكان؟ في التروما، واحد. اثنين، اذا في عندي كونترا انديكيشن للام ار اي سكان. الاكس رايز از فولينج فروم فيفر بصراحه، لانه سي تي سكان عم بعوض عنها، الام ار اي سكان عم بعوض عنها، بس ستيل اذا كان في حد منكم عم بيشتغل في مركز صحي في منطقه نائيه وعنده بس اكس راي، he still can do x-ray. Bone densitometry عشان to diagnose الاوستيوبوروسيس. Basic blood test CBC CRP ESR. CBC بنطلع على الوايت سيلز، بنشوف اذا كان في عندنا evidence of infection، نفس الشيء CRP. ESR في الانفلاماتوري conditions like rheumatoid arthritis it will be elevated. حتى بالانفكشن bacterial infection it can go up. Okay. مرضانا اجى بيشكي من severe low back pain, okay, with radiation down the S1 nerve root, اللي كان back of the thigh or down to the little finger, with numbness and paresthesia. The duration of pain كانت about 2 weeks, okay. وزي ما انتم شايفين, this is vertebra, this is a good well hydrated disc, this is another vertebrae. This disc space is slightly dehydrated because, as we said before, it lost the hyperintensity of it, so it is becoming degenerative. And then we have severe degeneration here, okay? So there's significant loss of height, okay? And we have a protruded segment of the disc, which is causing compression on the nerve root, on the S1 nerve root, on the axial cuff. Okay. This is still في هنا إذا شايفين hyper intensity والsignal من هذا الديسك is slightly isodense. It is not dark. Okay. So I decided that this could be or most likely to be a soft disk. وهو كان بالأربعينات إذا أنا متذكر صح بالأربعينات. This is a soft disk. في الexamination كان في عنده loss of the ankle reflex, which is explained by the S1 nerve root compression. Okay, intact sensation, and he has no weakness. Okay, well, this is the difference. If he had weakness, he shouldn't have surgery. If there's no weakness, ما بسوي surgery. الشغلة الثانية كانش عنده urinary أو stool incontinence. He was able to control his stool and he was continent to urine. بالتالي this one was a good indication for conservative treatment. This patient was given non-steroidal anti-inflammatory drugs for a couple of weeks. We added the gabapentin, progabalin for his treatment the week after, and gradually his pain started to improve until we reached within 2 weeks that his pain has improved by 80%. Once his pain has improved, we've sent him for physiotherapy, and I saw him like 4 or 5 months after the onset of his symptoms, and he was completely free of the radicular pain. The size of the disc is large, but still, we managed to treat this conservatively. Not every large disc on the MRI scan needs surgery. It is the symptoms of the patient that decides about the indication for surgery. Okay, when we do surgery for these patients, when there's failure of medical treatment, so I treated them for 3 to 6 months, and there is still of adequate, and this is important. The word adequate is the key word here, because sometimes some surgeons will give the patient some steroidals, they would disappear, non-steroidal anti-inflammatory, and they will come back and they say, well, we didn't get better. Okay, let's go ahead and do the surgery. You need to see these patients a bit more regular and see if they are having adequate treatment. And if it is adequate treatment, then that's fine. And it fails after 3 to 6 months. then they need surgery. The other indication, if they have neurological deficit from the outset. So if this patient comes to me with a foot drop of short duration, let's say 12 to 24 hours, I will operate on this patient as soon as possible to reverse his neurological deficit, because the presence of the neurological deficit signifies that there is compromise of the blood supply of this nerve root, and thus we need to act immediately before this becomes permanent. Okay. The last indication for surgery is the presence of Cauda equina syndrome, and we will talk about this in a minute. And this is a combination of loss of stool and urine incontinence in addition to radicular pain. Okay, let's look at this. This is another patient. I don't think this is a patient of mine. He has degenerative disease of the cervical spine. You can see that there is loss of height on multiple levels. Okay. And there is compromise of the spinal cord. So we lost the CSF signal anterior and posterior to the spinal cord. In addition, there's some osteophytes, which is better to be seen on the CT scan rather than on an MRI scan. And if you can look here also, there's some hypertrophy of the ligamentum flavum. This caused cervical canal stenosis, and this resulted on a signal in her spinal cord here, which signified that there is some ischemia. Patients with myelopathy, we should operate on them as soon as possible. If this patient has the typical symptoms or has symptoms of myelopathy, we would operate on them on the first available list. Not in the middle of the night, okay, but we'll try to schedule them as soon as possible. Again, this is another patient who came to us complaining of a neurogenic claudication. He was saying that his walking distance is limited to about 200, 300 meters, and then he will stop because of the abnormal feeling and the sensation in his leg. Once he will stop, his symptoms will disappear within 3 to 5 minutes, then he will walk again. He did not have any signs of symptoms of peripheral vascular disease. So his peripheral pulses were intact, his legs were warm. And this was enough for us to rule out vascular claudication and consider his symptoms secondary to neurogenic claudication. We started with conservative treatment. Though the likelihood that the conservative treatment will work is not high in these situations, but we still have to try it because sometimes some patients will respond to the treatment. The other thing, most of these patients with such a picture are elderly with multiple comorbidities. So if they do respond and they have limited activity, especially in our society, their activities is very limited. If they respond to some paracetamol, non-steroidal anti-inflammatory drugs, or neuropathic medication, then you don't have to operate on them. But if they fail medical treatment or they are still active and walk for long distances, you should consider surgery. So again, the same indication for surgery, which is failure of medical treatment for 3 to 6 months. If they have a neurological deficit that is explained by the affected nerve root and Cauda equina syndrome. The degenerative disease is very unlikely. The stenosis, very unusual that they present with neurological symptoms. Lastly, we'll talk about the Cauda equina syndrome. And I cannot stress enough that Cauda equina syndrome is a clinical diagnosis, not a radiological diagnosis. As you've seen in the first case, that the patient has a large disc prolapse that is compressing his Cauda equina, but still he did not have signs and symptoms of Cauda equina. And thus I don't treat the image as a Cauda equina and label him as a Cauda equina syndrome. What I need is a clinical diagnosis for Cauda equina. And when we talk about clinical diagnosis of Cauda equina, we should have involvement of the sacral segment of the Cauda equina, which means the nerve root between S1 and S4. And if you ask why the S1 and S4 are the hallmark, we'll go back to the anatomy. Let's have this one. Okay. If you remember from the anatomy, that the sacral segment is fused, okay? And thus there's no disc prolapses here. The last disc prolapse is between L5 and S1. So a large disc prolapse here will compress all the nerve roots below the S1. So S1, S2, S3, S4. Similarly, a large disc prolapse compressing the cauda equina at L4-5 will result in compression of all the sacral nerve roots in addition to the L5 nerve root. Another example is a disc prolapse here can cause compression on all the sacral segments in addition to L4 and the L5 nerve root. So what we noticed here that the sacral segment involvement or the sacral nerve root involvement is present on all levels of disc prolapses. And that's why sacral nerve pathologies is the hallmark of cauda equina syndrome. And this is why these patients, and please, there's something called complete cauda equina syndrome, and there's the partial cauda equina. For you, we are talking about a complete cauda equina syndrome. So for all these patients, sacral involvement is a must for the diagnosis. And this will include saddle anesthesia and paresthesia, which is anesthesia around the genital and perianal area, because these are the areas supplied by the S2 to the S4 nerve root, in addition to loss of, in addition to fecal incontinence and overflow incontinence. And this is very important to know the different types of incontinence. You will take this in urology rotation. I think it is in the 5th year rather than now. So it is overflow incontinence. So what happens in overflow incontinence? That you get urine retention because you lose the sensation in the trigone of the bladder. So the bladder will not contract and you will keep empty. Well, the patient, sorry, I use the بالطريقة العربية متعودين you. أنت بصير عندك هيك. فلا, the patient will get the loss of the bladder innervation. So he will not feel that he's filling his bladder. The bladder will continue to increase in size and having urine inside it, unless till the moment where the intravesical pressure or the pressure within the bladder will exceed the pressure of the internal and external bladder sphincters, and there will be a gush of urine coming out of the bladder, and this is what we call overflow urine incontinence. And most of these patients, because they have loss of sensation in the saddle area, they will not feel the urine coming out. What will they say? They will say, I wet myself. Okay, I've just noticed that I wet myself. كل وعيت بللت ما بعرف كيف ومتى. Or sometimes they will present with the bladder is up to the sternum موجود عندهم without emptying. I cannot stress it enough. 2 points in cauda equina. It is a clinical diagnosis. It is not radiology. This is one. The other thing, the involvement of the S1 to the S4 nerve root is the hallmark of cauda equina. It can be associated with radicular pain if there's involvement of the S1 nerve root of the L5, L4, but the hallmark is the involvement of the saddle anesthesia, saddle paresthesia, and urine and stool incontinence. Okay, it is an emergency, and we should operate on these patients within 24 hours, and they should have MRI scans as soon as possible. And this is one of the neurosurgical emergencies or spinal emergencies. The reason why it is emergency, because the longer you wait before operating, the less likely they will retain their autonomic functions of the stool and urine, which is a major cause of morbidity. And I think by this we finish the degenerative disease of the spine. We will have a few videos too. Okay, this will show you how the degeneration starts. Repetitive trauma, repetitive movement of the spine, okay, will result in loss of the annulus gradually, and there will be expansion of the nucleus bulbosus with degeneration, loss of its water content, and with time, this will protrude and cause compression either on the nerve roots or the spinal cord or the cauda equina. Okay. راح نشوف another video. Okay. This is video will show you how the nerve roots are coming out of the intervertebral foramen. Okay. And how we do the surgery. مش مطلوب منكم السيرجري itself، احنا بنسميها just بالنسبة لكم it is decompression. بنسوي skin incision. We split the muscles around it, and then we drill part of the lamina here. Okay. Once we drill this part of the lamina, we get access to the dura and the thecal sac. We retract the dura and the thecal sac to one side, and then we do the discectomy procedure. Okay. And the nerve root becomes relaxed and stop causing problems. This will show you the effect. Hopefully this is the right one. No. Okay, so we get the disc degeneration. زي ما لاحظتوا قبل شوي في عندنا abnormal movement، ببلش يصير في عندنا osteophytes زي ما انتم شايفينها هون، و changes في البون. These bone spares أو osteophytes will cause tightening of the canal. In addition to the diffuse disc bulge, this will cause the lumbar canal stenosis, which in the cervical spine will cause myelopathy, and the lumbar spine will cause neurogenic claudication and lumbar canal stenosis. I had a MRI scan of one of our patients who presented mainly with difficulty in controlling his hands, and he kept dropping objects from the hand. In further investigation, he admitted for having numbness and paresthesia in his hands, numbness and paresthesia in his feet also. And if you look at his lumbar MRI, cervical MRI scan, this is a sagittal views. You can see the spinal cord here surrounded by CSF, and you reach the level of C5, 6, and you can see that there is a disc prolapse here, and it is causing compression of the spinal cord. Okay. We'll have a look again. So this is the disc prolapse. You can see there's a cord signal and changes in the spinal cord, and he's definitely on examination had hyperreflexia and positive Hoffman sign, and it was good. He had indication for surgery. Okay, you see that this is the disc prolapse here. There's no CSF signal anymore, and we can see that there is compression on the spinal cord. Okay. When we, again, this is the disc. You can see the nerve roots, it is tight around them, and there's significant compression. Okay, this is his surgery. So we go from the front. We put these pins in the cervical spine to distract the disc spaces. And this is the disc space after it has been taken out. This is the posterior annulus ligament that I'm trying to take out. Of course, it is much slower in real life than what it looks in the video. Okay, this is still taking the posterior osteophytes gradually. Then again, drilling of the posterior osteophyte with a high-speed drill. So just remember, behind my drill is the spinal cord of this patient. So it cannot be that quick as it looks in the video. Okay, still taking soft tissue, moving forward, a bit more drilling, still drilling the posterior osteophyte. This is gradual, long process. Again, trying to dissect any soft tissues or osteophytes from the dura, keep going. And finally, we can see the shiny dura, and I'm still taking out more osteophytes. Once I've seen this dura here, just to clear the foramen, there's still some tissues around in the foramen. And at the end of the surgery, once everything is cleared, we measure a cage and we put a cage here to replace the intervertebral disc. Aisha. Aisha is one of our patients also. I will show you the difference how we treat with these patients. She came with severe radicular pain on the distribution of the C7 nerve root. And this was recent. It was around the mid of February, sometime like that. And she was offered surgery for, if you can see that there is a discus prolapse here, 2, 3, 4, 5, 6, 7, 2, 3, 4, 5, 6, yes, between C6 and 7. There's a disc prolapse here, which was compressing her nerve root, okay? Again, if you look at the mid-sagittal, you can see the continuation of the disc space here, the disc prolapse, slightly compressing her spinal cord. Then if we look at the axials, you can see that this is the nerve root. Sorry, this is the disc prolapse. It is hyperintense, which means that it is likely to be soft, and it is compressing the nerve root at its exit foramen. She came with severe arm pain. She was holding her arm without any movement. She had this MRI scan outside, and she was offered surgery for her radicular pain. We started her on medication, including neuropathic medications, pregabalin, I think, and nonsteroidals. And I saw her 2 weeks later, and she reassured me that her pain, she had no neurological deficit. Her pain has improved by about 50%, which is a great sign if the pain is improving. So not every disc needs surgery. Most of the disc space, disc prolapses, especially the acute one, will be treated conservatively, and conservative treatment do work for these patients. You don't have to do surgery for them. And this is the last example I wanted you to know, and we'll open it.